Bueno, buenas tardes. Vamos a iniciar nuestro seminario de esta tarde y me da mucho gusto presentarles al doctor Chad Bousman. Él tiene una licenciatura en Ciencias por la Universidad de Wisconsin, con especialidad en salud comunitaria. Después realizó una maestría en salud pública por la Universidad de San Diego, la Universidad Estatal de San Diego. Su doctorado lo realizó en epidemiología genética en la Universidad de California en San Diego. Y también realizó su primer postdoctorado en la Universidad de California en San Diego en neuropsicología. Después se cambió a Australia, donde hizo su segundo postdoctorado ya en farmacogenómica en la Universidad de Melbourne. Chad, a partir del 2012 al 16, fue nombrado miembro honorario, investigador honorario en el Instituto de Neurociencias y Salud Mental de Instituto Florey en Australia. En el 2017 al 2020 ya fue parte de los investigadores de la Universidad de Calgary, donde fue nombrado profesor asistente, y a partir del 2020 ya es profesor asociado en el Departamento de Genética, Psiquiatría, Fisiología y Farmacología Médica en la Escuela de Medicina de la Universidad de Calgary. Chad ha estado involucrado en los últimos años en entender o definir diferentes marcadores genéticos que se puedan aplicar a la medicina personalizada, especialmente tratar de entender cómo se puede traducir ese conocimiento a la práctica de la medicina psiquiátrica. En este sentido, ha desarrollado diferentes paneles de diagnóstico para predecir precisamente la aplicación a pacientes en tratamiento con desórdenes psiquiátricos. Ha validado y desarrollado diferentes herramientas para este propósito. Es miembro activo del consorcio llamado Farmacogenética Clínica, que está otra vez enfocado en aplicar este conocimiento en la medicina personalizada de pacientes con trastornos psiquiátricos. Chad ha dirigido alumnos de doctorado, maestría y de licenciatura, pero lo más importante que me gustaría resaltar es que también ha sido mentor de más de 30 estudiantes que estén interesados en esta área y siempre los encamina a seguir una carrera exitosa en la farmacogenómica y farmacogenética. Chad ha publicado más de 150 artículos y hoy nos va a hablar acerca del mismo tema, y cuyo título es ¿qué tan cerca estamos de la prescripción precisa de medicamentos psiquiátricos? Chad, thank you very much for accepting the invitation for being here.
Thank you. Thank you for that wonderful introduction. Okay. So today I have three main objectives for my talk. The first is I'm just going to provide a little bit of an explanation and rationale for the evidence for using pharmacogenetic guided prescribing. Then I'm going to provide a few care situations where pharmacogenetics could be useful. And I'll finish off by describing some of the considerations that we need to take into account when we're using pharmacogenetic guided prescribing in practice. So I like to start off with this quote when I do these talks, because I think it really captures the current state of prescribing. But it also highlights why we need more precise or more precision prescribing strategies. If we think about this in another way, at the population level, we know that medications are efficacious and tolerable. If they weren't, they wouldn't be approved by drug regulatory bodies such as the FDA. But if I take someone randomly out of the population and look at just them, it often looks something like this, where the efficacy and tolerability varies from drug to drug. So we're left with the situation of determining which drug fits in which one of these quadrants for a particular individual. Again, highlighting the need for more precision or personalized prescribing strategies. So here I'm just showing you a few personalized prescribing strategies that already exist. Most of these are very familiar to you. They've been around for decades and they're used in standard practice by physicians. Of course, today I'm going to focus to one of the newer personalized prescribing strategies, pharmacogenetics. But before I kind of dive into that, the one thing I do want to note is pharmacogenetics, it is a personalized prescribing strategy, but it's not going to replace these other strategies. The whole concept is that they'll be used in conjunction or companionship to improve prescribing overall. So what is pharmacogenetics? Well, basically, we're using genetic information to predict a person's ability to react or respond to a medication. And we typically divide this genetic information up into two broad categories. So one is the pharmacodynamics, so genetic variants that encode genes that encode for receptors, ion channel signaling pathways, and then the pharmacokinetics. So these are genes that encode enzymes or transporters related to absorption, distribution, metabolism, and elimination of drugs. Now, to date, pharmacogenomics is mainly focused on just the pharmacokinetics standpoint, and majority of the research and the evidence is focused on metabolism. There is a lot of research going on currently in the pharmacodynamics as well, but today I'm going to focus mainly on the metabolism because that is where most of the evidence is and where the clinical interface occurs. So when we think about metabolism in the context of pharmacogenetics, we're typically thinking about drug metabolizing enzymes. And then thankfully, over the last couple of decades, we have a lot of pharmacokinetic studies that have shown us that genetic variation in the genes that code for these drug metabolizing enzymes are a good predictor of someone's phenotype. In other words, their enzyme activity. And we typically define these phenotypes using one of these five phenotype characterizations: poor, intermediate, normal, rapid, or ultra rapid. So poor being slow enzyme activity, ultra rapid being fast. Now, if we know someone's predicted phenotype, we can usually do a pretty reasonable job of predicting how much of a drug will be in their blood at a standard dose. So those at that high risk end of the spectrum, which the poor or slow metabolizers, are going to be more likely to overshoot the therapeutic window at a standard dose and putting them at higher risk for side effects. Whereas those that are at the more fast end of the enzyme spectrum are going to be at risk for not receiving any benefit from that standard dose because they metabolize the drug so fast that it never gets into the therapeutic range. So this is great that we have a way of using genotype to predict an individual's phenotype. But the next question, of course, is which one of these which genes and which drugs can we actually implement this in practice? So to do this, of course, we have to look at the evidence. And like any other area, we're looking at the published literature. In pharmacogenetics, we're also looking at the drug labels. Drug labels have a wealth of information in them that has not necessarily been published in the typical scientific literature. We're also fortunate in pharmacogenomics to have a group at Stanford known as PharmGKB, or the Pharmacogenomics Knowledge Base, that collects all this information, so extracts all the information from the published literature, the drug labels, curates all this information, and then scores it on this scale, strength of evidence scale. So the first level there is unsupported, as the title would suggest. These are gene-drug associations that do not have any support for. So there's no association at this moment. The low level of evidence is where we see gene-drug pairs that there's a single positive study, or there's a number of studies that have been done, but there's conflicting findings. So there's no real consensus there. The moderate level of evidence is where we start to see replications occurring for this particular gene-drug pair, but the effect size is small, and some would argue that it's maybe not relevant to implement into clinical practice. And then finally, we have this high level of evidence, or where we have multiple replications again, but the effect size is large enough where we think this is time for clinical practice that needs to be translated. And it's these high level gene drug pairs that get pushed forward into the prescribing guideline development pipeline. There's now 4 major groups that develop guidelines, and I've listed those here. The top 2 are the most prominent and the ones that produce the most guidelines. So that top one is the Clinical Pharmacogenomics Implementation Consortium, or CPIC, which is based in the US and has an international membership. And then the second one is based in the Netherlands. It's the Dutch Pharmacogenomics Work Group. And those 2 collectively have produced most of the guidelines. There is a group in France, and there's also one in Canada, produced far fewer. But all together, these 4 groups have developed guidelines for 115 gene-drug pairs, comprising 25 genes and 88 drugs. And it's really shown nicely here in this figure. It's very busy, but you can see the scope of these guidelines. So it's not specific to any one drug class or even one area of medicine. So pharmacogenomics does have a large reach as of today. Now, of course, today I'm going to focus more on psychiatry. And so I'm just going to zoom in on the psychiatric medications. And you can see here we have 37 gene-drug pairs comprising 6 genes and 29 drugs. And I think you can probably appreciate right away there's 2 genes that really stick out in this figure. So CYP2D6 and CYP2C19. And they really are the workhorses for pharmacogenetics in psychiatry. Now, the other thing I want to mention is about 2 years ago now, the International Society for Psychiatric Genetics convened an expert group to review and come to a consensus on the current state of pharmacogenetic testing in psychiatry. And what they came up with after about a year of deliberations and reviewing the evidence was that the current evidence supports pharmacogenetic testing for specific antidepressants, antipsychotics, mood stabilizers, and ADHD meds. But they also suggested that the current evidence does not support testing for anxiolytics or hypnotics, addiction medications, or testing for genetic variants that are in pharmacodynamic genes. And I'm just listing a few here, but that's not an exhaustive list. Okay, so I want to provide you with a bit of a case example of how pharmacogenetics could be useful in the clinic. And this is a real case that was when I was in Melbourne in Australia. So this is a 67-year-old male with a diagnosis of major depressive disorder, and he was admitted to hospital with suicide ideation and catatonic symptoms. Now, prior to his admission, he was given trials of citalopram and escitalopram. So those of you that aren't familiar, those are SSRIs or antidepressants. And he was given doses at the maximum dose that was allowable, but he showed basically no response, minimal response. So the treatment team decided, well, let's try ECT, electroconvulsive therapy. And his mental state improved after ECT. And then he was prescribed sertraline before being discharged from the hospital. And sertraline is also an SSRI. Unfortunately, shortly after his discharge, his depressive symptoms reoccurred and he was readmitted to hospital. And this is when the team decided maybe we should order pharmacogenetic testing. So here's a summary of those results. So they ordered CYP2D6 and C19. Again, those are the 2, like I said, the workhorses of psychiatric pharmacogenetics. And you can see here for CYP2C19, this gentleman was a rapid metabolizer, and CYP2D6 a normal metabolizer. So let's unpack this a little bit and see what does this mean in this particular context. So first off, all 3 drugs that he was trialed on are CYP2C19 substrates. So all 3 of these are primarily metabolized by CYP2C19. Second, if we look at the drug labels for these 3 drugs, 2 of them, citalopram and escitalopram, have guidance or information about CYP2C19 genetic variation and dosing recommendations. There's also guidelines for all 3 of these drugs produced by CPIC. And what CPIC specifically says is if you are a CYP2C19 rapid metabolizer, you should consider an alternative drug not predominantly metabolized by CYP2C19. And then finally, if we look at the PharmGKB strength of evidence for all 3 of these gene drug pairs, you see they're all ranked at the high level. So again, multiple replications, large effect. So based on this information, sertraline was discontinued, and the treatment team decided to prescribe paroxetine. It's another SSRI, but the difference is this one is metabolized by CYP2D6, not CYP2C19. And if you remember, this gentleman, his CYP2D6 metabolizer status was normal. And the patient was discharged 3 weeks later, and he remains well in the community with no further relapses. So really the take-home message for this case is that pharmacogenetic testing can reduce these types of experiences and expedite time to response. So he trialed 3 antidepressants before finding the 4th one that actually worked. And he could also avoid unnecessary treatments. In this case, it's arguable that the ECT may not have been needed if they would have started paroxetine as the first. So it has some cost implications as well on the health system. Okay, so I've briefly already told you that there's a good amount of evidence, there's guidelines, there's professional groups that agree that pharmacogenetic testing should be used, and I just provided you a case example to show you that how it could be beneficial in a real-time clinic. I don't know why that happened. All right, it's back. But the problem is even though we have all that evidence and there's the clinical benefit, the adoption of pharmacogenetic testing has been modest as of yet. And this is globally and across all disciplines, not just psychiatry. And right now we're really sitting there in this early adopters phase. At least I would say in Canada and US we're here. Maybe other places in the world there may still be in this innovation phase. But we're approaching this, what they call the chasm, if we're talking about the innovation distribution curve. And in the chasm is where technologies or innovations are either going to sink or swim. If they cross the chasm, they make it into the early majority, that's where you get traction, and that's where things become standard of care. We're not there yet, so we're getting ready to make that jump, that leap. And so as a field, we're asking the question, can we cross the chasm? Well, in order to do that, there's a number of considerations that we have to deal with for this implementation to happen and get that traction. And I've listed a fair amount of them here. I don't have time to go into each one in detail, but I'm going to touch on them a little bit each within the time we have. So first is the selection and ordering. So by far, the number one question I get asked after giving talks or even during talks is, what test should I use? I want to order a test. Which test should I use? It's not an easy question to answer, and I'll tell you why in a second. But because we get asked this question so often, my colleagues and I have created this decision tree algorithm. Now, I know it's probably too small to read, but I've just put it up there so you know it exists. I'm going to boil it down into the 4 main components or best practices. So the first one is, of course, the test should be evidence-based. That probably goes unsaid to this audience, but it needs to be said. That complex figure I showed you that showed all the different gene-drug pairs that have guidelines, those are the ones that we want to make sure that are being tested or that those are included. If they're not in that figure, we should be weary. That's not an evidence-based test. Second, we want to make sure that the lab that is performing the test has some type of accreditation to ensure that there's a good amount of analytical validity that's going into the test. Third, so we need some transparency. What I mean by that is if the laboratory that's doing the test should be able to tell you how they're doing the testing, what they're testing, and most important, the process they're using to take the genetic information that they produce and translating it into a prescribing recommendation for the physician. If they can't tell you that or they're unwilling to tell you that, I would go somewhere else. That's a big red flag. And then finally, it needs to be supportive. And what I mean by that is we know at the current state that if you provide a physician a genotype or a genotype and a phenotype, it's probably not going to get translated into clinical care. There needs to be additional information attached to that, like a recommendation on dosing of particular drugs. Otherwise, they're not going to have the time to go look it up themselves. So it has to have some kind of support, decision support attached to it. And even better, having some kind of link to a pharmacogenomics expert or pharmacist that can help explain or walk them through it if necessary. The last thing I'm going to say about this is that, and the reason why I can't answer the question often when people ask me, what test should I use, is because there is no superior test. I've yet to come across a test that I can say, this one is best than everything I've seen. It just doesn't exist yet. So there is no superior test. And so it's difficult to say that just one you should use. But there are a number of inferior tests out there. And so these are the ones that we need to avoid. And by following these best practices, you're sure to stay clear of them. Okay, the second question that I often get asked around this selection ordering is, well, who should we be offering testing to? Now, ideally, we would say everyone. Everyone that is going to start a medication or maybe start a medication, we should just offer that. But let's be realistic. We don't have all the money in the world to just test everybody. It costs money to do this. So we need to be a bit smart about who we're going to offer testing to and who has get the most benefit out of the testing. And so to do this, I'm breaking it up into the three large age groups. So first, young people. So the evidence is still emerging here, but I would argue that this is the ideal population to implement testing. And this is because they have their whole life ahead of them. So this is where we have the greatest cost savings potential. Pharmacogenetic testing, I won't say it's a completely lifetime test, but we know our genome's not going to change. So those test results are going to stay pretty static. So we can continue using it throughout the lifespan. Maybe update some of the information, but for the most part, the genotype's not changing. So this is an ideal population in the sense they have their whole lives ahead of them and how many drugs they're going to be prescribed. So as far as the evidence currently in clinical indications, pretty much all SSRIs except for one, fluoxetine. That's the only one we don't have guidelines for. So if a young person is going to be starting an SSRI, I think that there's clinical indication that pharmacogenetic testing could be used to help select which of the SSRIs to start. And if risperidone or aripiprazole, two antipsychotics that are often used in first episode schizophrenia, often used also as adjuncts in treating of depression, these two also have good amount of evidence and guidelines. Now I've put stimulants up here with the thumbs down because currently we don't have good evidence to use pharmacogenetics to help select stimulants, so for the treatment of ADHD. There's a lot of labs out there, commercial labs, that will say they can help you pick an ADHD medication, but that's complete rubbish. There is no evidence for that. And that's just a sales tactic. It's not based in evidence. Okay, now switching to adults, this is where we have the strongest evidence. And it's mainly in major depressive disorder, which is where most of the implementation is occurring. And the clinical indications are quite broad. So anyone starting a drug with any of those pharmacogenetic guidelines that I showed you in that network figure has strong evidence for that. If a patient has no response despite documented high adherence, so they're taking their medication, they're still not responding, or they're having side effects at extremely low doses, this would be a good indication of pharmacogenetic testing might be helpful. And there's also some emerging evidence to suggest if a patient was maybe reluctant to start medications or is not taking their medications as prescribed, that offering pharmacogenetic testing may help in those processes, give them a bit more confidence that the drug is a good fit for them. And then finally, for the older adults, very similar to the young people, when there's not a lot of evidence, but it's emerging, the evidence that does exist does look promising. But I would say this is arguably the most challenging population to implement pharmacogenetics. And that's because we know there's a higher proportion of polypharmacy. And what I mean by polypharmacy is 5 or more drugs being taken at the same time. And we know that pharmacokinetics change with age. So as we age, our pharmacokinetics change. So there's a lot of assumptions that we can't keep as people age. Clinical indications are pretty much similar to the adult group, just with a little bit less evidence. And there's also emerging evidence to suggest if we're thinking about deprescribing medications, that pharmacogenetics may be helpful for making those decisions. Okay, now switching gears to content validity. So you may or may not know that currently there are no regulatory standards for what a laboratory can and cannot test for pharmacogenomics. So right now, if I start a lab, I can put pretty much whatever gene I want on my panel and put it out there with no regulation whatsoever. This leads to cautionary content. And what I mean by that are a lot of the genes that have good face validity and good biological plausibility. But when we look at the clinical evidence, the clinical validity is pretty much inconclusive. So to give you a few examples here, these are all related to mental health medications. But these all these genes, the ones in the red circles, are the genes all have very good good biological plausibility and face validity. So the first one there, the serotonin transporter and SSRIs. SSRIs interact with serotonin transporter. Good face validity, makes biological sense, but if you look at the evidence, it's not there. There's not enough evidence there to support using that gene to help advise on SSRIs. And I can make the same argument for each of those in this table here. Now the thing is they appear on these lab panels quite often, and that's shown here in these pie charts. You can see it's a non-trivial amount of lab tests that include one or more of these cautionary gene-drug pairs. So what does that leave us? Do we still use these panels even if they have one of these? Well, if you don't use a panel because they have one of these, you're left with very few panels because most of them include at least one cautionary gene-drug pair. So what I usually say is you don't necessarily have to throw the whole panel out, but I would ignore the results that are associated with those genes because it could lead you up the wrong path. And to highlight that, I have another case I want to share with you as soon as it comes back. Yep, I didn't touch it, I swear. So this is also a real case, 25-year-old male with diagnosis of schizophrenia. And he was admitted to hospital on an involuntary basis due to bizarre behavior and command hallucinations. And he had a history of multiple medication failures. And because of these multiple medication failures, the treatment team decided that clozapine was the next step. And for those of you that aren't familiar with clozapine, clozapine is the only FDA-approved drug for treatment-resistant schizophrenia. And in this case, this gentleman would definitely meet criteria given the number of failures that he's had before this. The problem is that the patient's family and the family doctor opposed him starting clozapine. And it was based on pharmacogenetic testing results that the family doctor had ordered prior to this admission. And so here's basically a summary of those results. And you can see they're, for the most part, unremarkable. He's a normal metabolizer across the board. But this particular lab decided they were going to test for a variant in the dopamine D2 receptor. And they specifically said that this gentleman's genotype predicted him to be a poor metabolizer and highlighted clozapine in the report as one of those. So based on this result, poor responder. Yeah, just responder. Yeah, not metabolizer. Yeah, poor responder. And because of this, the family doctor and family said, no, you're not starting him on clozapine. This test says he's not going to respond to it. So let's unpack this a little bit and have a look at what the evidence says. So first of all, if we look at the drug labels to genetic variation on any of the clozapine labels, there's currently no guidelines associated with DRD2 or clozapine from any of the major guideline developers. And if we look at PharmGKB's strength of evidence, this particular gene drug pair is rated as low. So again, not yet replicated or conflicting findings. And in this case, it's the conflicting findings. There's been quite a bit of research done on this gene drug pair, but no consensus. So taking this information in perspective, the treatment team approached the medical director and the patient and got approval and consent and decided to start clozapine, even though the patient's family and the family doctor opposed it. And the patient responded rapidly, was discharged, and he gradually returned to his previous level of functioning. So the take-home message here is that we really need to be careful about when we're implementing pharmacogenetics, that we're only implementing gene drug pairs that have prescribing guidelines, that strong evidence base. When we stray from the guidelines, as they did in this case, you make the potential that you're going to take a very efficacious medication off the table for a patient. And he'd already, as you've seen, failed so many antipsychotics. So what was the other alternative? So we have to be very careful to stick to the guidelines. Okay, one of the other questions I always get asked is, what clinical trials say? We're actually fortunate that we have 13 clinical trials have been done, 10 randomized clinical controlled trials. And we just finished this a couple months ago. This is a meta-analysis of those clinical trials looking at efficacy of antidepressants if pharmacogenetic testing is offered. And what you can see here is if we look at the pooled odds or relative risk for this, patients that receive pharmacogenetic guided antidepressant treatment were 41% more likely to remit relative to the patients that receive standard of care. So there's a good amount of evidence from clinical trials. I think 41% is a very good number for a simple test that you can use with saliva. And again, this is just antidepressants. Related to this, cost effectiveness. So we often get asked, well, that's great, it has a good effect, but how much is it going to cost us and is it going to be effective? Most evaluations suggest pharmacogenetic testing is cost effective or even cost savings when you compare it to standard of care. There's 108 studies that have been done. This is across all pharmacogenomics, not just in psychiatry. If we look at psychiatry, there's been 11 studies. And you can see if you just focus on the green parts of the pie there, you can see that's the majority of the studies. Those are the cost-effective and cost-saving studies. So majority of studies do show that it's cost-effective or cost-saving. We also know that if we offer pharmacogenetic testing, it reduces healthcare utilization. So it reduces hospitalizations, emergency room visits, and healthcare provider visits. So it keeps people well longer, keeps them out of the clinic, presumably working, going about their daily business. And we also know it saves money overall. So overall costs have been estimated somewhere between $6,000 and $7,000 per patient per year savings. And this is US dollars. Okay, so another consideration, and probably one of some of the biggest challenges are around feasibility. So how do we actually do this, right? So the science is great, but how do we actually do this? So there's so many things I could talk about here, but I'm going to pick the 3 top ones that are currently plaguing the field. The first is EHR or EMR integration. So how do we get this information into the electronic medical record, or even if we're not talking electronic, just the medical record in general? And few institutions globally have really accomplished this. In fact, most of us are sitting here at this level 4, level 3, where it's a paper-based, it's maybe been scanned into an electronic database, or usually it's in a paper chart buried somewhere, and you have to know which tab to look at, where it is, and who put it there, and why is it there. So it's often a fact-finding mission to find these reports, unless you're the one that put it in there. What we're trying to do is shift more towards this level 1 or level 2, where the information is in a static place that alerts physicians, this is for the electronic medical or health record, when they prescribe a medication that has a link to that gene. So this is already being done in a few institutions. So if a physician tries to order a drug and it has a link to a particular gene for that patient, and let's say they're a poor metabolizer, it pops up a warning saying you're about to prescribe this, they're a poor metabolizer, do you still want to do that? And it often will give alternatives. Like I said, very few have done this, but this is kind of the way of the future and what we're trying to do. Just make it part of the workflow. Physicians don't even have to think about it. It just pops up in front of them. Another big challenge for everyone is healthcare providers' confidence in their knowledge of pharmacogenetics. So I don't know specifically here in Mexico, but in the US, Canada, Australia, where I've worked, healthcare providers are not getting pharmacogenetic training. Unless pharmacists are the only exception. Some pharmacy schools now are incorporating pharmacogenetics into their curriculum, but med schools aren't doing it, very few. So when they hit the wards or they're in the clinics, pharmacogenetics, some of them haven't even heard of the term. So it's a very difficult sell when we're saying, hey, you want to use this test? Well, I'm not really sure about this. And so it gets to be a very challenging component of adoption if doctors aren't on board. And then finally, always the elephant in the room is the affordability of the testing. So country to country, wide range of how much this costs. In the US is the most because of the way that the system's set up. It's variable, it's inequitable. Not everyone always has access to it. It's usually the people that can pay out of pocket that get access to it. And the other thing is the cost of the testing does not correlate with quality. So in the US, average cost is around $1,500 US. That's just extortionate amount of money to pay for a test. And they're not doing any better testing than we are in Canada, where we still are charging a high amount too, 500 Canadian, so about 5,000 pesos for a test, which I think is too high as well, particularly given that we can do this testing for under $100. Like that's the actual cost of the testing. So there's a huge markup on this testing, and we need to address that so that it's more equitable and accessible to all patients. Okay, and the final consideration I want to touch on today is about the interpretation. And this is, I already kind of touched on a little bit about the clinical decision support, but we know that if you don't provide clinical decision support, interpretation doesn't really happen very well. And we wanted to look at some of the labs that already are offering this, some commercial labs, and how they're offering clinical decision support. So we designed this head-to-head comparison study where we recruited 5 individuals. We asked them all to give us a sample, 4 samples of saliva, so 4 independent samples, and we sent them off to 4 different labs. And those labs didn't know. We just sent the same sample. And then when the results came back, we compared each individual's test for all 4 labs. We wanted to see how consistent the results were across different labs. And to our surprise, less than 60% agreed on the advice that they were given. So patient 1, test 1 said, this person can take the normal dose. Another test said, nope, they should have an increased dose. And another test may say, lower the dose. And so it was all over the place. And so we were very surprised that there wasn't some consistency there. And so the take-home message for us was that these clinical decision support tools cannot be assumed to be equivalent or interchangeable. But it also raised the question of why. Why aren't they getting to the same result? And part of that is what we call the black box. So if we just look at the genotyping results from those companies, they almost have perfect concordance. So they are all getting the same genotype. It wasn't the genotyping that was the problem. It was how they were interpreting that genotype and making it into a prescribing recommendation. So that spot in between the genotype results and what we tell the physician is what we call the black box. How are they making those decisions? So we know some of the ingredients in the box, but we don't know exactly how they're weighting the information and how they're using those ingredients. So what do we do about that? Well, one way is to bypass the black box. So like I said before, we have these guidelines produced by these groups. They're completely free available. You don't have to have any subscription to access these guidelines. Anyone can look them up. So if you have someone's genotype, you can go straight to the guidelines. You don't have to rely on the lab's interpretation. The problem with that, of course, is who has time to go look up every single guideline for every single gene result? No one does. Nobody wants to do it, and nobody wants to be assigned that task. So we have to have some tools to deal with that. So one of the tools that we've developed in Calgary to help with this is basically a second opinion tool that helps you bypass the black box. So you get a test result, you're not sure if you believe the results. You can put it into this is sequence to script. You enter their genetic results in, and it only pulls in the recommendations from these expert groups, the ones, the CPIC, Dutch Pharmacogenomics Work Group, and FDA, and puts it all into a nice report that you can then compare to the other. So you're getting that second opinion. It's done pretty quickly. You don't have to go and look up everything. The other consideration, I believe this is the last consideration that I have for you, is we've been talking about genetics, but the non-genetic factors can also impact on the interpretation of results. And what I mean by that is phenoconversion. So phenoconversion is a phenomenon in which a person's genotype, predicted phenotype, doesn't match what we see in the clinic. So let me give you an example. So let's say I genotype someone for CYP2D6, and the results come back, they're a normal metabolizer. But then I look at their medication list, I'm like, oh, they're currently taking fluoxetine, right? So fluoxetine, it's an SSRI, it is a potent CYP2D6 inhibitor. So while someone is taking fluoxetine, they're no longer going to be a normal metabolizer. They're going to phenoconvert to a poor metabolizer as long as they're taking that medication. So if we don't take that into account, If I just look at them and say, oh, they're a normal metabolizer, and I ignore the fact that they're taking fluoxetine, I may prescribe a dose that's not going to be right for them because they're really going to be a poor metabolizer, and I could induce a side effect in that sense. And just to show you how often this can occur, so this was a study of 900 patients with depression, and they genotyped all of those 900 for CYP2D6, and they found that just genotype alone, 4% of them were poor metabolizers, which is what we would expect in this population. It was a European population, so 4% are poor metabolizers. But then they went and looked at their medication list, and when they looked at the medication list and seen how many were taking inhibitors and that would be actually poor metabolizers clinically, 27%. So you can see there's a huge disconnect there, and it really highlights why we need to take into account these other factors. The one caveat I will say is this was in an older aged group, so a lot more polypharmacy. We may not see as drastic of a difference if we were talking about kids because they're not taking usually as many medications. To help with that, again, there are tools to help with the phenoconversion. I already mentioned sequence to script. It takes into account phenoconversion. If you tell sequence to script what drugs a person's currently on, it'll make that adjustment for you. And there's another phenoconversion tool called PROP. That's just for CYP2D6, but sequence to script does all the genes. Okay, so I'll finish off with just 3 take-home points. First, I hope that I've shown you that pharmacogenetic testing is an evidence-based strategy to inform prescribing of commonly used psychiatric medications. When we're using pharmacogenetic testing, it's extremely important that we adhere to available guidelines. And if you know someone that's using pharmacogenetic testing, really push them to follow those guidelines, and don't forget about the non-genetic factors. Again, that phenoconversion piece. And then finally, pharmacogenetic testing is just one tool. It's a companion decision support tool that can enhance, not replace, current strategies that are already being used in the clinic. With that, I'll stop. I'm happy to take questions, and thank you for your attention.
¿Preguntas? Las personas que nos están viendo por Zoom o YouTube, por favor, escriban sus preguntas en el chat y acá las leemos para que las escuche el ponente y las pueda responder.
First question I would like to ask you is, why is it that the emphasis in or the abundance of data is on pharmacokinetics and adults? So that bias, is that inherent to the knowledge of pharmacogenomics or to the difficulty in obtaining data, or is more historical thing? And can it be circumvented by more naive data collecting without previous hypothesis? Is that something that you think it will impact the field?
Yeah, so it is a bit of both. So definitely historical in that pharmacogenetics started with drug metabolizing enzymes because we understood those first. They were the easiest to understand. And before we had pharmacogenomics, we had a way of phenotyping people, giving them a small bit of a drug that we knew got metabolized through a certain enzyme and measuring it in their urine. And so we had a good phenotype that then we could marry with the pharmacogenomics. So I think metabolism has been the focus because it was the easiest to tackle first. Adults, I think it's more of an ethical thing. Like it's just easier to do these experiments with adults. It is building in children now. My whole research program is based in child and adolescents. So we're definitely doing that. But and the other thing is pharmacokinetics is coming. And that's because now we have GWAS, we have whole genome, exome. So we're getting a lot more for our money when we do genetic testing. We don't have to just focus on one gene. In fact, it's usually frowned upon to look at just one gene. Usually saying, if you're going to do genetic testing, you should just do as much as you can. So I think it is going to come, but pharmacodynamics, I know you're aware, is so complex. And it doesn't help that most psychiatric medications we really don't know how they work. We know they get to the brain, and then it's like mystical. right? Like what's going on in there? We know maybe what receptor they attach to, but after that, who knows? So I think we have our work cut out for us, but I think with these high throughput types of technologies, it's going to make it easier for us. And with like stem cell technologies and organoids and things like that, we're going to be able to really crack this soon.
¿Alguna otra pregunta?
Thank you. Thank you for such a nice, fantastic talk. Well, I'm sure pharmacogenetics is for all kinds of diseases, right? It's not for psychiatric diseases.
Mm-hmm.
But I was wondering, I mean, how to make this kind of strategy more to lower the price so everyone can have access. And also, we were talking this morning, I mean, you might find some key enzymes, key molecules to treat the specific diseases, but in a specific population.
Mm-hmm.
That might not be the same for Latin American people, for instance.
Yeah. So the first question about the cost, it's a tricky one. I mean, like I said, it's not expensive to do genotyping. Most of you in this room have probably extracted DNA and have done some type of genotyping or something. You've worked with DNA at some point. It's not a complex process. It's pretty simple to do. To me, it comes out to flat out greed. I think a lot of the labs are just trying to make a lot of money off of people that are willing to pay. It can be done cheap and efficiently and accurately. Like I said, under $100 Canadian, we do it in our lab for $75. That's how much it just costs us from the reagents that we have to buy and things like that. But if you were to do it at scale, like we're doing it in a research project, right? 14 samples a week. That's not really high throughput. If you were to scale that to the population, you could do hundreds of samples a week. The price is going to go down, right? So I mean, I could see it being per person could be $20, something like that. I mean, it could be really cheap if you did it at scale. And in a place like Mexico City, it could be really cheap if it was implemented standard, and it wouldn't be that expensive to do. If you think about how much it costs to do other standard tests, $100 a test is not even thought about, right? Cardiologists run tests all the time that are more expensive than that, and they have to keep doing it. It's not a test that they can keep using. They have to continue doing it. We're only asking for a one-time. It probably lasts you for a good 10 years before you have to redo it because new discoveries. So I think the cost thing is fixable, but it's going to take a little bit of political will to do it. And the second question about the differences of different populations, that's a trickier one. That's why research needs to be done not just in European populations, which is where most of it's been done. It does need to be done in specific populations where it's going to be implemented. Ideally, before you implement, doing some of the research to make sure that the markers and the panels that are using are relevant to your population. And that's going to be a case by case or region by region kind of decision. That's the best I can do with that one. Yeah.
Thank you.
Yeah, can I ask you two? I think brief response questions could be. One is, why is it that it's not taught to the medical students? Is it that hard? I mean, it's pretty simple, conceptually, I think. So why do you think that it is not part of a normal curriculum already? And the other question is, do you think that polygenic risk scores are going to have a place in pharmacogenomics? Because none of the current clinical indications are based on any polygenic risk score, is it? Or a polygenic score?
No.
Do you think it will be taken, or is it useful in the field?
Okay. So first one, why is it not in medical schools curriculum? I can only speak from the medical schools that I've tried to push it into. It's about space. they're trying to cram so much information into medical students' brains that if I said, hey, can we just get an hour lecture? Like, can I just do an hour lecture? That's all I want. Like, well, if we give you an hour, who are we kicking out? Because we're packed. So someone else, we have to say, you can't give your lecture anymore. So it's a matter of space, and no one wants to extend medical school longer than it already is. And some of you that are thinking about going are thinking, no, don't do that. So that's one of the main reasons. And that's why I've kind of pivoted away from, I don't think physicians are the ones that should be doing the pharmacogenetic testing. I think it should be pharmacists. Pharmacists, they're drug experts. All we have to do is teach them about the genetics, which is not, like you said, complex. This isn't complex genetics. And they'll understand this because it's related to PK and PD, which is their whole training was about PK and PD. So we're pivoting towards, let's work with the pharmacist, and then they work with the physician, and that's like the team. Some physicians don't like that idea, but I think they'll come around because they're not going to get it in their training. They're going to have to want to do it after, as part of like continuing medical education. Polygenic risk scores. So there are a number of studies that have been done now to see if there's a polygenic risk score for, let's say, antidepressant response. They're statistically significant. I'll say that, and they get into nice journals. But when you look at how much of the variance in antidepressant response does the polygenic risk score explain? Around 3 to 4%. That's not enough to put it into practice. It's a good start, but I think it's going to take a while for us to really get polygenic risk scores implemented from a pharmacogenetic perspective. And the problem is the way polygenic risk scores are calculated. So right now it's individual variants that are weighted based on their odds ratio or whatever, right? But when we're talking about pharmacogenetics, most of the stuff we're looking at are haplotypes. And polygenic risk scores don't take into account the haplotypes, which is how we determine whether someone's a poor, intermediate, normal metabolizer. So there just needs to be some adjustment for pharmacogenetics. And I know it's bioinformatically possible. Not for me, I don't have that knowledge, but I know there's bioinformaticians or budding ones in the audience. So this is something to look at. Like, how do you accommodate in a polygenic risk score other types of genetic structure? They also don't take into account copy number variation or anything else in the polygenic risk score. So I think that's why we're getting such low variance explained. And I think it's not because it's not a powerful tool, it's just the way it's being applied.
There is a question in YouTube, and they ask why these guidelines are not included in resistant depression or other psychiatric disorders before testing with different treatments, like randomly.
So what was the first part of the question?
Why not your guidelines are included already in when there is an indications for depression resistant?
Why aren't we doing the testing?
Why don't do the tests initially? Why
wait till they're treated? Yeah, well, that's the big question, right? So it's like offering fire safety training after you smell smoke, right? That doesn't really do you much good at that point. But it comes down to cost, right? So a lot of places in the states that have reimbursed it, they're saying you must already have shown at least one failure or side effect to a medication before we're going to offer this testing. And so it's basically saying you must suffer one thing first before we give you the thing that can stop the suffering. So it's a bit wrong, but everyone jumped at it because at least they're reimbursing it. So the preemptive, which is what I think the person asking the question is getting to, why aren't we preemptively just offering this at the start? It just comes down to cost. But that is what we want to do. It should be done. Some people are advocating for even it be included as part of the newborn screening. So they already do genetic testing. Just add a couple more, get the pharmacogenetic profile from that. It's a good idea, but I don't know how feasible it will be to do. There's still some resistance to that.
¿Alguna otra pregunta?
I wanted to ask you about, well, I don't know much about how the studies that do this association of variants in the genotype are completely correlated to phenotype. Just that I do wonder if they do assess that kind of risk, that not always a genetic variation is gonna correlate to a phenotype.
Mm-hmm. So the genotype, the phenotype, how strong is that correlation?
Yeah.
Yeah. So for the P450 enzyme ones, it's pretty strong. And so, like I said, it's based off of about 2 decades of work showing if you do those phenotype tests where we give someone just a little bit of a drug that we know is metabolized, measure in their urine the metabolite, and then we do genotyping of the gene, and we see, does that correlate? And it's not perfect. It's not a correlation of 1, but it maps pretty well. You see that nice diagonal that you want. Part of the reason why it's not perfect is the phenoconversion component, right? So a lot of those studies were done, like I said, a decade or 2 decades ago. People weren't thinking about phenoconversion, and so they didn't always, we didn't know how all these enzymes were inhibited or induced. We knew about some. And so some of those patients may have been taking other things. It's not just drugs. Inflammation can inhibit a lot of these. So if you just have a cold, a virus or something, it could inhibit your enzymes. If you're taking an oral contraceptive, that can do changes. If you're smoking, these are all things that could have affected those previous studies, which is why I don't think it's a perfect correlation. But we're talking, 0.8 or above. It's pretty good. And that's why we say predicted phenotype. We typically we'll say this is your phenotype, because we really don't know. It's what we predict to be your phenotype based on your genotype.
Okay, and I also, it jumped to my attention when you said the part of the elderlies, where you said it's not that easy to implement pharmacogenetics because their PKs tend to change with age. Is it already being studied how it could be changing, so we could also predict how those PKs be at that moment of life, so we could still implement pharmacogenetics?
Yeah, I mean, so a lot of physicians will run, they'll do renal testing, or they'll do a liver panel to see if, how well is your hepatic functioning and renal functioning. That's really all that can be done at the moment. I mean, that's the standard that's done, but it's not often done, particularly in psychiatry. Psychiatrists don't always order those things. Not to say there are psychiatrists that do it, but I think that's one of the challenges. And then the real challenge, though, is the polypharmacy. And when I mean older age, I'm saying 65 plus. That's when we kind of see the drop in PK, but we also know that age group often is taking 5 or more medications for various different things from various different doctors. And those doctors don't always talk to each other. And if a doctor sees another medication that they don't know much about, they leave it alone. They're like, I'm not touching that. I'll let that doctor deal with it. But so that's another problem. This is another reason why I think pharmacists need to be involved, because pharmacists are agnostic, right? They know the drugs, so they can help, like, those two going together with this genotype, this is a red flag, right? So yeah, I think it's a challenge for sure. I'm not saying we shouldn't use it in the older age. It's more of a challenge. There's a lot more variables at play. Yeah.
Una última pregunta. Bueno, si no, tampoco tenemos por Zoom. Thank you very much, Chad, for your nice presentation.